we have tried, if you connect yourself with the lab activities and with the resource material which has been provided, the quality of the stuff, and so many other things, and I'm sure you'll be enjoying it, and it will not be that content heavy. What I'm trying to say, it's not content heavy on anatomy part. Okay, guys, so now I think we better start. So now, in the posterior abdominal wall, what we are expected to be learning. So what we are expected to be learning, we'll be talking about bones, muscles, lumbar plexus again. You have done it before, so it will be just a revisit. Abdominal aorta, you know it already, but we'll be talking about its all branches today. And then inferior vena cava, everybody has an idea during your GI block, you have spent time on that, so it will be a revisit, but you'll be knowing, you are expected to be knowing about its tributaries. So anything above to this orange line, that will be covered in today's session. And the coming things, the kidneys will be covering in the next lecture, ureters a lecture after, and these adrenal glands or suprarenal glands will be covering in year 2, inshallah. So basically, we'll be more focused for these 5 structures today. Are we clear? Okay. Without any further delay, I have brought an X-ray for you. And this X-ray is showing something. What you see in this X-ray? Can you write? Spine, excellent. Lumbar spine, excellent. See guys, now you are exhausted, but you are pro also. Everybody is good. So you are looking at the lumbar spine. And there are few things, I will talk about it later. Normally, it should not be straight. It should be little curved. Why and what is happening, we'll be talking about it. Okay. So now, this is I told you in the first part of my presentation, we'll be having bones. And this is, we are looking at the bones here. And what bones has become visible to you, you can see that the lumbar vertebrae has been shown to you. You're looking at the rib cage, but we're not talking about ribs any further, only the lower 2 ribs. And then these coxal bones or the hip bones and part of the sacrum, we're not going in their details, but we'll be doing. So this is our focus area where I'm encircling. So now, let's put the words here so that can be helpful for us. So primarily, this is the posterior abdominal wall, and we'll be introducing a new term here, retroperitoneum. The word retroperitoneum is not new for you. You have learned it when we were talking about peritoneum. The word retroperitoneum means, practically speaking, anything behind the peritoneum. So that is a retroperitoneum. So basically, most of the structures which are related to our renal learning in this whole block, these structures are primarily, all of them, they live behind the peritoneum. So they are the retroperitoneal structure. I hope this word is clear. And then what are the major landmarks of importance? There are so many things, but we are not wasting our time. Guys, you are requested and it has been expected from you. Just connect with the things. And what has been visible on the course for the name of the lab, I have tried to provide small basis of every explanation, and that will be really helpful for your ongoing learning. So we'll be talking about the lower ribs, 11th and 12th, the lumbar vertebrae, 1 to 5, and then little bit part of these bones, the coxal bones or the hip bones, sacrum little bit. So now, this is the basis. And on top of that, we will be making everything. So let's go further. So now you're looking at a lumbar vertebrae. So let's label it. I'm sure you all know its different parts. What is this part? Can you write it? What is this part? Body, excellent. See, you guys are pro now. So this is body, excellent. And let's give, it's the pedicle. What about this? Transverse process. And what about this? This is a little different. We didn't talk about it. Lamina will be from the front. That we will not call. Yes, excellent. This is something, mammillary process. Then we have spine. Spine is very different from our thoracic spine. and then the mammillary process. So this much if you know about. And then kidney shaped body. Excellent, Sarah. You are helping me. You guys are, mashallah, now superstars. So we are good with the lumbar vertebrae. If you know this much from a lumbar vertebrae, nobody can stop you. Now, let's start making the major structures of the posterior abdominal wall and the retroperitoneum. So I like you to stay focused. Now what we see here, what are the landmarks? Abdullah, now focus here. What I'm trying to show you here. So this is the sacrum, we all know. Iliac crest, iliac fossa, this is all MSK. We talk about it. Ischium, pubis, anterior superior iliac spine, pubic tubercle, pubic symphysis. What is this? You remember? Greater trochanter of the femur, lesser trochanter. So now, this is what the diaphragm is. Excellent. And we are not taking the whole diaphragm, only the posterior part of the diaphragm, posterior inferior part of the diaphragm. So this we all know, this different color, the fibrous material, the central tendon of the diaphragm. Are we good with that? So this is the central tendon. Going further, this is the muscular part. And now you can see that in between, we have these openings which have been guarded by these different sphincters. And these we call it as cruras. You remember we talk about median, medial, and lateral arcuate ligaments. So see, we are just doing what we did yesterday. So this is what the esophagus, we all know it passes at T10 vertebrae level. Along with, what are these yellow things? Any idea? What are these two yellow things? Vagi. Excellent. Don't write phrenic. These are the vagi. Then there is another thing, another band which is shown with gray, and that is a passage, we call it median arcuate ligament, and what passes through it? Yes, aorta, abdominal aorta. And then we all know from the central tendon, what passes is the inferior vena cava. See, I can see, mashallah, the whole class is well connected and people are really doing good. I'm impressed. And if you go with this pace, nobody can stop you from getting an A. Now, inferior vena cava, we are good with that. And now this is where I'm showing you phrenic. Somebody was talking, thinking that this is phrenic. No, that is vagus and this is phrenic. That is arranged in the peripheries. Aorta T12, yes, we, T12, L1, but we accept more at T12. Abdominal aorta T12, L1. These are the levels being mentioned for that. It's actually in between. So phrenic now we have seen both right and left sides. Now let's put the muscles who contribute in making. Do we have to know the roots? No need, no need. Just simply C3, 4, 5. One of the phrenic nerve passes through the, yeah, you guys see, mashallah, you are doing good. So now let's focus on the muscles who contribute in making my posterior abdominal wall. So we know about this muscle. We all see that this is psoas major. Excellent. Then this is iliacus. There we have now the psoas and iliacus join together and make one common tendon. We call it iliopsoas. And you can see that it's going to the lesser trochanter of the femur. See, we did it yesterday and mashallah, you are good with this. So that shows you are best people I'm blessed with. So iliopsoas tendon is visible to us. And then we can see this green thing. This is the inguinal ligament. We learn during GI how and where it is being formed. Excellent. And now these are two quadrangular muscles, and these are in the lumbar region, quadratus lumborum, having 4 angles, quadra, 1, 2, 3, 4 angles. So these are located just above the iliac crest and they are going upward. So these are next to my psoas major muscle. Psoas minor, you may find it, you may not find it. It's okay. Now, 11th and 12th ribs, we talk about them. They have been visible here. And now this one going transversely. This muscle contribute in anterior abdominal wall. This muscle contribute in posterior abdominal wall. This muscle contribute in anterior abdominal wall. And then this is the sympathetic chain and it meets in the midline in the lower. What is lagging, guys? The sound cut off, doctor. Still the same? Okay. So I was talking about this is sympathetic chain. You didn't hear it contribute to what? Transversus abdominis muscle contribute to the anterior abdominal wall. This was I was saying about that. So now the place where my sympathetic chain in the midline in the bottom part, that is called ganglion impar. That's a name. If you know it, it's fine. If you don't know it, it's okay. So now we talk about this median and medial and lateral arcuate ligaments. Just a quick revisit of that material. So I'm sure everybody is fine. So now there is a small quiz for you. It's a very baby quiz. I'll be putting a number and you have to tell me, what is this, guys? Write on the chat box. Sauce, excellent. So you are learning. Everybody is learning. Okay, what is this number 2? Number 2. Perfect. So you are good. We are done. So now let's start revisiting the lumbar plexus. Now I want you all to stay focused with this because this concept is a little bit interesting. Okay. So now I have to shift this chat thing. This is really helpful. So now, so these are the contributing parts. These are the spinal nerves. Who are these? Ventral rami of which spinal nerves? L1, 2, 3, 4, and 5. So they are responsible in giving us the lumbar plexus. So now what happens? It's very easy. It's not like your other plexuses. It's very simple and very easy, and I'm sure you all have done it. So simply what you have to remember, from the L1, we have from the root, we have two contribution. Both of them are emerging from the L1. So they are iliohypogastric and ilioinguinal nerves. Just remember this, L1, iliohypogastric, ilioinguinal. Now from the root of the L1 and L2, I have two more contribution and they are giving me what? Genitofemoral nerve. Having two components, one is the genital component and one is the femoral branch. Guys, this femoral branch has to do nothing with the main femoral nerve. Don't mix it with that. This is a sensory part. Now from the L2 and L3, I have another nerve and that is called lateral cutaneous nerve of the thigh. It's really important and you need to know about it because we love to ask from this. How? I will tell you. Now from L2, 3 and 4, it's anterior division and a posterior division. They are giving us two nerves. One is femoral and the other one is obturator. So both of them are coming from L2, L3 and L4, but one comes from the anterior and one comes from the posterior. So somebody is asking, genitofemoral nerve has a genital branch and a femoral branch. Genital branch goes to the genitalia and femoral branch just supplies the skin above the femoral triangle. So now you have to figure it out which one is anterior and which one is posterior. This is a task for you guys. Yazan has given already the answer. Yes, Yazan. The obturator is anterior and femoral is a posterior from the anterior division and a posterior division of ventral rami. I hope everybody knows. Everybody is good with that. Yes, you guys are pro. Femoral is posterior and obturator is anterior. And then now from L4 and L5, we have lumbosacral trunk. This lumbosacral trunk, it contributes, it joins with the sacral plexus and that is making my sciatic nerve. So see how simple it is. So this is the lumbar plexus. Now whole of this lumbar plexus is formed where? In the posterior abdominal wall, and everything is underneath, is hidden under a muscle. But before going to that, you are expected to be good with these. That iliohypogastric nerve, what are its areas of supplies? This is really important. What is coming now with these small black words for iliohypogastric, for ilioinguinal, for genitofemoral, for all of them. And I request you all, please read them and be good with these words, that what are their areas of supply. Repeat the interior and exterior of nerves. Yusuf, I didn't talk about interior and exterior. I just said the ventral rami of my L2, 3, and 4. They divide into anterior and posterior. The anterior becomes the obturator and the posterior becomes the femoral nerve. Is the accessory obturator in accessory means it is there, it may not be there. So we are not talking about this. What was the number 2 in the first quiz to confirm quadratus lumborum, if I'm not wrong? So, but what is expected from you, other than knowing these names, you should be able to understand what are, if this nerve is being cut, what are we losing? If this nerve is being cut, what are we losing? So similarly, if there is an injury to any of these nerves, so what functions has been lost? So a very nice MCQ can be designed. Somebody presented with this much losses. Which of the following nerve is being damaged? Simple. So if you know these functions, and these functions are associated with which nerve, I don't see any problem that you cannot solve this MCQ. Now, all this plexus is formed within the substance of the psoas major muscle. So it is all happening under the psoas major muscle. So if you take off the psoas major muscle, you will see all of them. And I'm sure when you'll be visiting, those of you who have visited in the lab resource place, in the section of posterior abdominal wall, we have put the real images, and one image was showing psoas major is in place and the nerves has been emerging from its lateral border and medial border and all that. And the one where we have removed the psoas major muscle, so you can see that what are the differences which are occurring at that pertinent level. Okay, guys. So now the psoas major muscle is being there and everything is happening inside, all the roots. And this is the, now let's look into an image. Why does it says the red front from, I will talk about it later, Ragat. So now just focus here. Look at it on this side. The psoas major is in place and here psoas major muscle is being removed. You're looking at the diaphragm, quadratus lumborum, transversus abdominis, iliacus, and psoas. Here psoas is present. So you can see that this is my subcostal nerve, L1, iliohypogastric, ilioinguinal, lateral cutaneous nerve of the thigh. And then this is the femoral nerve. This is the genitofemoral nerve. And on the medial side, you'll be having obturator. Guys, something is very important, which is connected to this nerve. This is the lateral cutaneous nerve of the thigh, and it is worth mentioning. And I can figure it out where it is being written here. No, it will be coming in my next slide. Remind me, I have to tell you about this, some really important fact. So here you can see the psoas is in place, so everything is hidden. And when we remove the psoas, when we cut the psoas major muscle, so under the psoas, you can see how this lumbar plexus has been formed, and you can see the positioning of the beginning of your sacral plexus, your obturator, your femoral nerve, and other these nerves, and the sympathetic chain, everything is being well placed. What is the nerve which is penetrating the psoas major muscle? That nerve is genitofemoral nerve. So if you allow me to say, I think in my next slide, I will be explaining in more detail about this. So now, lumbar plexus, everybody is good with that. So now let's try to put things in a way so it can help you in better understanding. Okay, guys. So we all are good. This is psoas. This is okay. This is my first nerve which is coming up here. Who's that nerve? This one. This is my. And remember, these nerves are coming from where? From the lateral border. This is the lateral border of the psoas. This is the medial border of the psoas. So this nerve is what? Subcostal, excellent. No, it's not iliohypogastric, it is a subcostal nerve. And then what do we have here? Now this is my iliohypogastric. I told you L1 bifurcates into iliohypogastric and ilioinguinal. So you can see both of them. How I identify on a cadaver that this is subcostal nerve? The simplest idea, feel for the 12th rib. If you can feel the 12th rib, just below to that, just close to that, should be my subcostal nerve. And I can tell you one thing, when you'll be visiting your labs next week and after, we'll place these cadavers and we'll make sure that you should be able to identify these nerves on the cadaver. So be good with them. And not only good with their names, but be good with their areas of supply. So if something is missing, so you should be able to connect yourself which nerve is gone. So these are your ilioinguinal and iliohypogastric, both L1. I can tell you one tricky question. Let's say you are confused and you are seeing only one, the second one is not there. You can survive very easily by seeing L1 because both of them are L1. So learn to play smart when you forget something. And now this one, see, this is going laterally towards my upper thigh. No, it's not genitofemoral. Look at it, it's coming from the lateral border. It's not coming from the front. This is the lateral cutaneous nerve of the thigh. And this lateral cutaneous nerve of the thigh is really important and we need to know a lot about that. Now look at it. Below to that, we have femoral nerve. It is also, so how many nerves coming from the lateral border of the psoas? Subcostal, iliohypogastric, ilioinguinal, lateral cutaneous nerve of the thigh, and femoral. So 1, 2, 3, 4, and 5. Excellent. You guys are pros. So now we'll be looking at, so these were the nerves which are coming from the lateral side. And now the nerves emerging medial. So now focus in this area. So what is coming up here? That should be your area of focus. So now you're looking at somebody who's going down. We all know this is nothing but the obturator nerve. And it passed through the obturator foramina. And then this one, lumbosacral trunk, which joins with the sacral plexus in making. So you can see that they are making. Is the lateral cutaneous nerve medial to the isis? Yes, this is the place for isis. So it's going so close. It's going so close to that. It's very close to that. And it is important because this nerve has so many names. I'll be telling about those. So now we have seen. So now those people who are in habit of wearing very tight clothes, they are in trouble. When this nerve is being compressed because of the compression, and this syndrome has so many names. People call it Calvin-Klein syndrome and other things. It's a funny thing, but people love to ask about that in the exams. And you should be knowing about. So now people were asking about, now I have shown you the nerves which are emerging from the lateral border. Then we have seen the nerves which are emerging from the medial border of the psoas, and then the nerves which are coming from the front part of the psoas. And that one is the genitofemoral nerve. So femoral branch, we know that, and genital branch. And now this is the point, what I was talking. Look at this red arrow. So is worth reading. The lateral cutaneous nerve of the thigh may become compressed here from tight clothing and lead to tingling, numbness, pain along the lateral aspect of the thigh. So this patient may present with these signs and can come to your clinic. And we have so many names for that. One of the name is myalgia paresthetica. This is a scientific name. But in other words, people also call it Calvin-Klein syndrome. So you advise this person, stop wearing very tight clothing and which are especially compressing near to your lateral aspect of the thigh. So not Calvin-Klein clothing, Calvin-Klein syndrome, because the tight clothing, I'm not saying Calvin-Klein make only the tight clothing, but it's given a name, but this is the scientific name. So this nerve is compressed, a patient might experience these kind of things. And the moment the person stops wearing the very tight clothes, how tight are we talking about? Because it's just a fabric. Look, there are flexible tights and there are some super tight of clothes which really cause some compression. Once you take them off, you can find that impression has been imprinted on your skin and on your body. I'm not talking about the flexible dresses. No, they are flexible and there our body can breathe in. So, but this point is worth remembering. Don't ignore it. Okay, now, sympathetic trunk, we know about it, ganglion impar, nothing significant. Now, what we have done so far, we have talked about the bones which contribute in making my posterior abdominal wall. Then we have learned about the muscles who contribute in making of my posterior abdominal wall. And then we have seen the nerves who contribute in making of my posterior abdominal wall. So, policeman, I like this. So now we'll be talking about the arteries. Guys, this is an important thing. And I expect everybody should be really focused because it has a lot of content and you all are expected to be good with that. So now let's start. What we have now abdominal aorta. It begins its journey at T12L1 level and it reaches to the fourth lumbar vertebrae at L4 where it bifurcates into common iliacs. And common iliacs divides into external iliac and internal iliac. You can see them, the external iliac passing under the inguinal ligament going to the femoral triangle, supplying our thigh. And the internal iliac going to the pelvic cavity and is a sole artery to be supplying the pelvic organs. Now, going further. So aorta, T12L1 to L4, that is a must-know type of information. So now what I'm showing you here, I'll be talking about aorta gives 5 pairs of somatic branches. So what are these? So these 5 pairs of somatic branches. By word soma, soma it means body cavities. So you can see one of them. This is going under the diaphragm. Suggest a name. So right and left, inferior phrenic, because we also have superior phrenic, Omar. So these are right and left inferior phrenic arteries. Then we have these arteries which are shown only on this side, but they are not shown on the other side. And these, can you see them? These are 4 to 5 lumbar arteries. And they are also being shown on the other side because here we are showing muscles. So I cannot show you underneath. So you can see that 1, 2, 3, 4, 5. 4 to 5, we have lumbar arteries. Left side, they are not shown. Then we have covered what? 5 paired somatic branches. So this was the first pair, inferior phrenics. And then we have 4 lumbar arteries, both on the right side and on the left side. So these are my 5 paired somatic branches. Then I have 3 paired visceral branches. So what are these? They are paired. They are not single. Excellent. So now celiac trunk is not paired, gentlemen. So now right and left middle suprarenal arteries. So these are coming from the aorta also. So what are these? Right and left middle suprarenal arteries. And then we have renal arteries. Excellent. You people have wrote it already in the chat. And then lastly, we have on both the sides, these are the one who goes to the gonads. These are the gonadal arteries. So primarily what we have 3 paired visceral branches and 5 paired somatic branches. Gonadal, in case of male, we call them testicular. In case of female, we call them ovarian. So we can change, and the common word is gonadal. I hope we are good with these paired branches which are coming from my aorta. 5 somatic and 3 visceral. 3 pairs of visceral branches. Going further, now from the inferior phrenic arteries, we have so many branches. If you don't know them, it's okay. But once we make for always. What is the difference between somatic and visceral? Fada, the word somatic is from soma. Soma means body cavity and viscera means organ. So I'm sure by now you should be knowing that what is a viscera and what is a body cavity. You can see that this one was going to the under surface of the diaphragm and these are going to the organs. Renal is going to the kidney. Gonadal is going to the testis or the ovaries. And this one, suprarenal, is also a gland. So these are going to the organs. So now renal artery, it gives even further branches. You can see them. So renal artery gives also contribution to the suprarenal. If you don't know it, it's okay. What is the difference between somatic and visceral? I think I have talked about it. Okay, now, after that, what do we have? We have now 3 unpaired visceral branches. Previously, we were talking about the paired ones. So now we are talking about unpaired. So first, we all know celiac trunk, and you are good with that. That is the artery of the foregut. Excellent. You guys are mashallah pros. And then the superior mesenteric artery for the midgut, and then we have inferior mesenteric artery for the hindgut. Excellent. So these are 3 unpaired visceral branches. And then story doesn't end here. We have 3 terminal branches. So what are the terminal branches? So today I'm sure you will understand what is the different terminology which has been used when we'll be talking about branches. So what are the terminal branches? So my aorta continues as what? So terminal branches. So we have right and left common iliac arteries. So these are the terminal branches. And then we need to have more. And then we have median sacral artery. So you can see that there's a one tiny artery like a tail which runs in the middle. So this is the median sacral artery. So these are my terminal branches. Are we good with that? So we have, these are the branches. So 2 common iliacs and 1 median sacral artery. So that gives me 3 terminal branches. If I quickly recap, external iliac is then branches from common iliac. Now aorta is over. But we were talking at the moment, we were talking about the branches of the abdominal aorta. And what we said, we have 5 paired somatic branches. Then we have 3 paired visceral branches. Then we have 3 unpaired visceral branches. And then we have 3 terminal branches. Should we mention the branches of the unpaired visceral branches? Yes, now you should be able to know all of them because we have completed the whole cycle, that what are the visceral paired and what are the visceral unpaired, what are the somatic paired and what are the somatic unpaired, and then what are the terminal branches. So now femoral artery, look, femoral artery, all these, they are now branches of continuation of external iliac. Then internal iliac gives so many branches. We have to know inferior phrenic nerves. No, not really at the moment. Just they are just being mentioned. Right now we are talking about the arteries. I hope everybody is good with that. So now we'll shift to the veins, but before that, I'd like to show you some more images. They'll be, so now on a cadaver, when you'll visit your cadaver, you'll see the abdominal aorta like that. And you can see now you can very easily figure it out who are, you can name these branches. You can see the suprarenal, you can see the renal, you can see the gonadal. Can you see the paired ones? These are the real images. You can see the inferior mesenteric, superior and celiac trunk. They have been shown here. Celiac trunk, superior mesenteric, inferior mesenteric. So everything is being shown only if you connect yourself. Then there you can see another image, and this is the explanation of the same image. It's been labeled now. So you can read this stuff and that will be helpful for you. I'm sure we have talked about aorta, where it begins, where it ends, and what are the branches has been given up by this aorta. Are we good with that? Perfect. So now, again, one last revisit. So you can see all those branches in action. And now I'm sure everybody can understand who are the paired somatic, who are the paired visceral, and who are those, the solitary branches which are coming from the front, and every branch has been shown. Celiac trunk L1, and then, renal L2, and then L3 and L4, and everything is being mentioned here. So now, let's talk about the veins. We are good with the arteries. Let's start filling the veins. So now veins, the story is reverse. My inferior vena cava is formed at L5, fifth lumbar vertebrae, and then it begins its journey. Its destination is to reach the right atrium of the heart. So let's start making. And It pierces the diaphragm. Look at it. It starts its journey. Two common iliacs, they join to form my inferior vena cava. It passes, it is formed where at L5, and it goes towards the diaphragm. It passes through the central tendon of the diaphragm, and it will be T8. Excellent. So L5 to T8. Excellent gait. I love you. So now inferior vena cava, you have seen it. Now let's making it further. So you can see that the femorals and all that has been shown, external iliacs just for. Now, it has three terminal tributaries. So who are its three terminal tributaries? Now you guys are smart. Just learn to play. Right and left common iliacs. And then you can see the median sacral. Guys, it's just the reverse what we have done for the arteries most of the times. 5 paired somatic tributaries. Everybody can answer it. You can see them. I need not to talk about them. Excellent. So you guys are, mashallah, amazing. And I'm really proud of you guys. You are doing a good job. I'm just moving something so I can shift the things from. Yes. So now we are looking at the visceral tributaries. So my visceral tributaries are, you guys have given answers already. Hepatic veins, you can see them. Renal veins, right and left. Now, there is a little catch here. The left renal vein, what is about this left renal vein? The left renal vein, you can see that it's longer. It crosses over the abdominal aorta, and then it is being crossed by superior mesenteric artery. So in other terms, the renal vein, the left renal vein is sandwiched between the superior mesenteric artery in front and abdominal aorta behind. So if a person has an aneurysm of superior mesenteric artery or an aneurysm of abdominal aorta at this level, this vein will be compressed. Excellent, Momo. Nutcracker syndrome. So that situation, if that happens, we call it a nutcracker syndrome. And then this vein is compressed, and how this patient will present to you. That's something important. Why is important? We'll be seeing in a minute. So the left renal vein is being drained by suprarenal opens here, and then something very important, left gonadal vein. So you can see that the left gonadal vein and the right gonadal vein. So right gonadal vein is going to the inferior vena cava. But where is the left gonadal vein? You can see that it is opening not into the inferior vena cava, it is going and opening into the renal vein. So now as a result, if this is being compressed or there is a problem with the valves, so now if this is a male patient, so this person might develop varicocele. What is varicocele? In Arabic, you call it dawali. In the scrotum, it feels like, if you feel this scrotum, it feels like a bag of worms. And why this has happened? Because the veins, the venous drainage is not now as good. So the veins which have been present, which has been surrounding the testes, they become engorged, they remain filled with the blood, and they will become, you can feel them. You can on examination, you can feel something is been there, and that is a problem. And these people, they have issues when they are getting married. So now they are being fathers, they have trouble. And usually when it investigated, one of the common factor in male infertility pattern is having these varicosities, the Wali varicose veins. And the results are good after this surgery is being done, and we'll take care of these varicose veins. It's a long topic, we'll discuss some other time. But just in a short story, only you should remember that left gonadal vein is not going to the inferior vena cava directly, it drains into the left renal vein, but the right gonadal vein is going to the inferior vena cava directly. So drain into inferior vena cava, right one, left one through the renal vein, through the left renal vein also goes to the inferior vena cava, but not directly. You can see in this image. Are we good with this concept? Okay, so now we are fine with that. So suprarenal veins we have seen. So guys, we have seen the bones, muscles, arteries, veins. Now let's talk about the lymphatics. And the lymph nodes, we have group of lymph nodes, they are present and they are named according to the name of the arteries. So what are the names given to them? You can see that we can name them accordingly. So you have celiac nodes because they are present across the celiac trunk. And then what do we have next? You can see them, they are present across the superior mesenteric, so we can name them accordingly. Inferior mesenteric nodes, vice versa. So this is how we can name them. And they all, the para-aortic nodes, drain the foregut, midgut, and hindgut respectively, and end up in cisterna chyli, and then it becomes the thoracic duct. We all know about it. We talk about that. And look at them. So I have given a different color to those who are present across the aorta. So these are the para-aortic, because they are parallel to the aorta. So we call them para-aortic. They are present across the celiac trunk, so we call them celiac nodes. Superior mesenteric nodes, inferior mesenteric nodes, vice versa. The lymph nodes have been named according to the blood vessels. And guys, knowing about lymph nodes is really important because they are really helpful when we are handling with the patients who are having some cancer. And for the staging of the cancer diseases, the knowledge of lymphatics is really, really, really important. I'm sure your HLS block, you have spent good time in learning about the immunity and the lymphatics and everything. So now para-aortics, we talk about them across the aorta. I have given them a separate color, and this is what the cisterna chyli, which has been shown here, and ultimately it becomes the thoracic duct, and it goes and open. Are we clear so far? Any issue? Okay, guys. So we are good with that. So we have seen it. So the lymph nodes present across the common iliacs, we call it common iliac nodes, external iliac nodes, internal iliac nodes, femoral nodes. Similarly, the names has been given. Now what we're seeing here, previously we have seen the veins, arteries. Now we are looking at the inferior vena cava. Look at it in a real cadaveric situation. This is the aorta. This is the inferior vena cava. Look at the left renal vein. See it yourself. It's a cadaveric image. Look at the left gonadal vein. It's not going to the inferior vena cava. It's opening here. You can see everything. Suprarenal is being shown. Left renal vein, you can see that is being crossed. If there is an aneurysm, we talked about that. So everything is visible. It's made at L5 and it's going towards the diaphragm, inferior vena cava. Are we good with that? So now I've just outlined everything, so it will become more add-on visual to you. So this is how it is, a neat picture, and this is the explanation of this image, which has been with the labeled version. I'm sure you are good with that, and everybody knows about its tributaries. Where is the suprarenal? Okay, guys. So now you can see in situ on a picture how, remember one simple rule. Aorta slightly left, and inferior vena cava, all the veins on the right side, all the arteries, major arteries on the left side. This is really helpful when we are handling the sections, and sectional anatomy is always part of our learning. What are those three cut veins? You remember, it's been labeled here, hepatic. Read the label, gentlemen. Now, this is what? A reconstructive, this is an angiogram, a very specific, this is a reconstruction. This is a radiological image. This is a reconstruction and everything is being shown. What we have talked about, the abdominal aorta and its different branches, everything is being shown to you. Yazin, what's your question? Can you unmute yourself and ask your question? Okay, by mistake. It's no problem. So now, this is I just kept these things for you. Muscle of the posterior abdominal wall. You need to be good. This is minimum required. You can read these lines. I'm not reading it for you. So guys, in summary, we are good with the diaphragm. We are good with the aorta and its branches. We are good with the tributaries of inferior vena cava. And we are good with these nerves who are contributing in making and supplying here. Any question? Now I'm open to your questions. We are almost done with our first session of our renal block, the anatomy session. Above kidneys are seen fats. No, this is not fat. This is suprarenal gland. These are suprarenal glands. What does tributary mean? Tributary is another word. You know, for artery, we always say artery gives branches, branches. And for the vein, these small veins join to form a big vein. So these who are contributing towards a big vein, these are the tributaries. Tributaries join to form a vein, and artery gives branches. Cisterna chyli is at lower level. The question which we put, I remember what are you referring at? That is, this is referring somewhere L1, L2 level. Suprarenal arteries run above the kidneys. Don't pay much attention to the suprarenal arteries because I have to talk about all about the branches. That's why it's been shown to you. But suprarenal arteries, leave it for endo-repro block. When you'll be coming, inshallah, after your summer holidays, we'll be talking. Why is the right kidney lower than the left one? Ola, if you go to my videos, where you can find them, you can find them in Lab Resource Center. And also I'll be sharing with you, I have made some YouTube activity, so you can watch live updates on different learning activities on that YouTube session, and you'll find everything is there. But this, why the right kidney is lower, I can answer you here. Right kidney is lower because we have liver here, and because of the liver, it has been pushed downwards. Thank you, Kanis. So my resource material will be visible at different places, so you can go and listen and you can watch. I really appreciate. So I'm confused on the posterior abdominal wall artery. I remember Dr. Sadia said on structure of the week on GI that inferior mesenteric artery gives median sacral, and here the picture shows it comes from the abdominal aorta. We'll talk about it. Don't worry, Abdullah. When you'll be coming to lab, remind me. I'll be handling with this question. Which all the veins drain into the, remember, all the veins drain into the left renal vein. Look, left renal vein is receiving what? Left gonadal vein. And it is also receiving the suprarenal from the suprarenal. And then this left renal is going to the inferior vena cava. The right renal vein is not getting any gonadal veins, but it is receiving the suprarenal veins, and then it is going to the inferior vena cava. Doctor, at L5 we have to common iliac vein. Yes, exactly. The common iliac, the two right and left common iliac vein, they join at L5 to make inferior vena cava. What is the most common cause of left renal vein compression? Number one, incompetency of the valves. Number two, there is some tumor, there is some obstruction at the hilum of the kidney. Which kidney? Left kidney. Number three, nutcracker syndrome. So there are so many causes which may result in the compression of the left. That's why if you take these people, those who present with this varicocele or Diwali, you will see that it is more commonly seen on the left side as compared to the right side. What most common cause of the left renal vein compression? I think Marjana have answered this question. Any other question, guys? So let's proceed further. So this is the time to say you thank you, but thank you for this presentation, but I'm open and available. I encourage you all for any question, for any queries, write to me. It's better if you use the discussion forum, it will be useful for everybody, but I'm open on direct thing, and you can ask me next week in the lab session, or all about where you can find me. If you're really looking for me, where I'm available. Thank you very much. Stay blessed, take care, and bye-bye.